Conference. I think all of us would agree with me and join me in congratulating you for the warmth and the caring you've shown all the participants in this conference. And we do thank you very much. And they'll hear about you back in the U.S. as long as it's becoming open. On our panel, we have a rather distinguished group. We have Dr. Brown from Beverly Hills, and of course Dr. Hashmani from Cannes and Rio de Janeiro and Beverly Hills and the world, and Dr. Giorgio Fischer from Rome. And the doctor, I'm having a bit of a problem pronouncing it. That's what I say, yeah. He's from Thailand. And to my left is a wonderful lecturer, as you heard this morning, Dr. Richard Khalil, who's a professor of surgery and cosmetic surgery in Chicago. Today I think we're going to discuss a procedure that is often talked about and I think has wonderful indications when used properly. We're going to talk about a thing that dermabrasion, but I've been experimenting now for the last, I guess, about 7 years with a procedure that I've been using called chemodermabrasion. I'm going to get into that later on, the reasons for it, and why I've chosen to modify the actual dermabrasion procedure using what I call, excuse me, I have a little allergy, chemodermabrasion. I've done a series now of over 1,500 patients in the last few years. Almost every patient that I do a dermabrasion on, for whatever the indication, may it be cystic acne, and mind you, dermabrasion or chemodermabrasion is an excellent indication for treatment of active cystic acne. Many doctors say, well, wait till the acne dies down. That's completely wrong in my feeling, because as acne heals, as you all well know, it will scar the face, and you can't allow that. Even though acne, there's no cure for acne, and a new drug called Accutane is not a cure-all, and I use it very reservedly because, as you well know, it causes mutagenic changes, especially in females. A woman who's on it, for example, it's a primary indication for abortion. And that's why the woman is taking Accutane in the childbearing years. It's essential for the doctor to do monthly pregnancy tests. I think if you don't do that and she gets pregnant, that's malpractice, in my opinion, at least. But even though dermabrasion, when I say dermabrasion in the future, I will mean chemodermabrasion, because that's just basically what I do just about. What involves the entire face. By the way, if you have any problem hearing us or understanding us, you might raise your hand and I'll try to clarify. Being that I never write these things out, I have to speak a little slower, so if I get too quick, just raise your hand and I will slow down. Thank you very much. Again, to get back to that point, chemodermabrasion is an excellent indication for active cystic acne. Even though it's not a cure, it will certainly lessen the severity of acne, and it will much less frequency of going to the doctor's office, and it can do an awful lot for a child's or even an active adult's psyche, because the mind, as you well know, is scarred as much, if not more, than the skin in active cystic disease. Now I do this procedure, excuse me, for, again, active cystic acne, burnt out, scarred acne. I do it for trauma cases, patients who've been scarred perhaps going through a windshield or in an accident. I also do it for sometimes raised scars of the face. I dermabrate. And I also find an excellent use for it in what I consider the severely sun-damaged skin, actinically damaged skin. It's a particularly excellent modality. And I should show you some photographs. I brought quite a few along, but I'm going to show you about 4 or 5 cases that I've done. Now, I think what I'm going to do is just quickly run through the way I proceed in dermabrasion. I'm sure you've all done them, and I'm sure you've all had some excellent results, and you've had some which may not be as excellent. But I think that if I will mention this procedure, you will find, you may believe or concur with the way I do it, or you may pick up some little pointers you want to ask us about, and we might discuss it. Most important thing, I think, is good photographs. Tell the patient what you plan to do. Explain to them that the scarring of the face is something that you really have to level out. It won't go away by itself. Many patients feel that we'll talk in this case about acne patients, which is the most prevalent condition, I would think, for chemodermabrasion. And we give them a mirror and we point out the scarring and we explain to them that it will never just go away. And I try to compare the scarring of the face to a road that's been damaged, that it has to be planed down and go from there. Now, many patients feel that collagen or something, or silicone, which I never use silicone, by the way, in the face. I definitely believe it moves. It's never been approved for use. And I was one of the first to use collagen, and at least in my hands, I'm pleased with the results of collagen. I think it really is a lot of technique, and I think there are a lot of doctors doing the collagen, but I think they have to pay a little more attention, the vast majority, to the actual technique. And we'll go into that later also. Remember, in the collagen injection, you must raise a white bleb on top of the skin, otherwise you're too deep and it's not going to work. But we'll go into that later also. Those are what we call the fine tuning after the major tuning, which I call the chemodermabrasion. The fine tuning is later the collagen or punch grafting or punch elevation, which we shall also describe later on. All right, so first of all, it's important to have a good consultation with your patient. Gain that patient's confidence, because chances are when they come to you for a dermabrasion or chemodermabrasion, they've gone to 4 or 5 doctors and they're just very disappointed and they have a negative feeling in general about the doctor. So it's most essentially, so I found in my practice, to really gain this person's confidence. Maybe an adolescent, it may be someone in their 20s or 30s, but explain to them, show them some photographs, let them talk to your patients in the waiting room who's had it done. I have found that's my best way of explaining to a patient something. Let them talk to somebody who's had it done. Patients are the most cooperative after they've had something done to share their experience with somebody else. It really works. I walk out of my consultation room and let the patient who I'm going to treat talk to somebody who's had it done. I find it to be a wonderful modality, at least in my office. All right. Then we're talking about the photographs. The patient's face is cleansed by the nurse with betadine. The patient the night before is NPO, nothing by mouth, after 12 o'clock in the night. I don't have any aspirin or aspirin-containing substances for at least 7 days before surgery. Patient comes in immediately, even if I have a case ahead of them. My nurse brings them into one of our waiting room, and we give them 10 milligrams of Valium, depending upon the patient, maybe 5 milligrams, depending upon weight. IM, so they relax and they get in the mood, as we say. And then we give them a set of earphones, and they can relax. They can sit in the room with their family and take it nice and easy. At that time, the nurse walks in and begins with the ice packs. I believe in within 45 minutes to an hour before surgery, I use those ice packs that are sent to me by the Collagen Corporation when I get the boxes of collagen. And those things are wonderful. You put them right back in your freezer, and you take them out whenever you want to, and you just wrap it and put it on the patient's face. It really works. And we were talking yesterday about the hypothermia. I think it's a very helpful adjunct. It minimizes the pain, it minimizes bleeding. For me, it works, because as I operate, I also use a Frigiderm to make the face more cold. But I also like the fact that the freezing technique is very effective, at least in my hands. If you don't have those things from Collagen Corporation, take an operating room glove. Put some ice cubes into it or a plastic bag, tie it up. It's terrific. The patient then comes to my operating room. We operate in the office or at the hospital. I just find it's much more convenient for me to operate in my office. We begin, patient is, I put this special facelift drape on at the forehead to keep the hair out of my peel. And I, again, begin to cleanse again. We do it twice, because I don't trust completely what my girls do. I want to do it myself. I put cotton in the ears for 2 reasons. They can't hear me swear, and they don't get any blood in the ears. It serves 2 purposes. Then I think marking the face is very important. I mark the face, I try to do it in two positions. I put my operating table up so I can see the scarring in different lights and the angle, so I can get a nice silhouette. And I mark it with gentian violet. After that, I begin to inject the face. I inject the face in 6 sites, which are sensory to the face. I use 1% xylocaine with epinephrine, a total of about 15 to 20 cc's, and these are the sites I'm using. Above the eyebrow, directly adjacent to the nasolabial area, and right here to both sides of the chin. And I find that will take care of sensation in the face. I find it's a very good trick, and it's half the battle is gone when you do that. After that, I begin some other medication. If the patient is a very anxious patient, I start some D5W, which is dextrose and water for the translation, and I have Valium ready in the intravenous line. We've already given the patient 50 milligrams of Demerol and 25 milligrams of Phenergan. So before I even touch the patient, intramuscularly, they have Valium, Demerol, and Phenergan. And these drugs, for me at least, seem to summate. Phenergan I've been using the last few years. I find it to be very effective. They feel nice, very soporific. They feel very, very comfortable. I begin my procedure, and another little tricky point I like. If you use a fan when you operate, when I use a Frigiderm, a fan will make the Frigiderm even harder, which gives me even a harder surface. Now, some of you don't like to use a freezing agent. I find it's effective. I use either Frigiderm or ethyl chloride. I am careful with ethyl chloride. I'm also careful with Frigiderm because in a very darkly pigmented patient, and I've done black patients, I've done Chinese, I've done every type of race, I've not had a problem. If you're scared about pigmentation, it might be to your advantage to first do a little test dose right behind the ear 10 days before the surgery, just to reassure yourself that pigmentation will begin as healing progresses. And that's another consideration. Usually, the pigmentation of the eye will dictate how these patients will heal. After I've done the freeze, again, either ethyl chloride or Frigiderm, I prefer the Frigiderm. The fan will help because it makes it even harder. I wear a raincoat and a special shield that one of the doctors showed us before with his special, our friend from London, to protect myself so I don't get my face all covered. And on my blood test before, I often now take an Australia antigen. I don't want hepatitis, so I do a CBC, a fasting blood sugar, and Australia antigen, and VDRL, routinely for dermabrasion patients. And I think it's important because I know some doctors do dermabrasions without gloves. I think that's a mistake. It's a very bloody thing, and you never know. So to protect yourself, certainly it's a good idea. After the thing that's also most important is that you go through a special regimen that your office staff knows you the same thing as far as the actual procedure each and every time. It is best to begin your dermabrasion with inferior area first, that being the case that the blood will flow down away from the field. If you begin up here and you're going down, you're going to have blood all over the place and you're not going to be able to see what you're doing. So that's very important. Begin inferiorly and work in areas, break up the face into certain areas. For example, on the right side of the face where I always begin, I'll do it in about 4 areas. 1, 2, 3, 4. Okay? But as you see, I try to get the most dependent areas first. And then I usually go around to the mouth, go back to the left side of the face, and then I go back into these areas in here. Now, another trick that I like to tell you about is when you are doing the mouth, and that's a tricky thing, around here and around the eyes, I'm always changing my diamond phrase. I've used the brushes, I've used everything. I find for me the medium to coarse diamond phrase for the average patient, and for the one I want to do a light chemodermabrasion, I use a lighter wheel. It depends upon what width you prefer. I prefer one that's about 1/8 of an inch, and a mild to coarse. At least for me, they're very effective. I always make sure that they're well cleansed and sterilized, and you can use them many, many times. They will wear out after a time, but they're pretty durable. I use a German steel one. They're excellent. After I've arrived at this area, to the mouth, I change to the bullet. Now, the bullet is a small little device. It's shaped just like that, and you can go into areas such as the nasolabial area. You can do your upper lip. You can do Adam's Cupid's bow. You can go anything you want and not have a problem because, for example, if I'm doing the mouth, as I think you've seen before on these films, put your finger in the patient's mouth. That's why I prefer a nice deep local. The patient can assist. In the general, I don't have that kind of assistance. Put your finger right in the mouth and raise up, and you can go all over the whole mouth. and you're following, and you're always protecting your teeth. I've had a lot of, I think a good part of my practice, maybe more than 50% of my patients are patients sent to me by other doctors who've done dermabrasion. I do a lot of repair work. Because I think of all the procedures in cosmetic surgery, after the rhinoplasty, dermabrasion can be the most dangerous, because in a matter of fraction of a second, things can happen. I've seen eyebrows taken off, I've seen teeth chipped, all kinds of terrible things can happen. So you must tell your staff, keep your eye on the field at all times. There's no reason to take your face away from that field. That is the most important. And also, I think it's essential that one protects the eye. One must protect the eye no matter where you are. What's to happen if one of those wheels should get loose? And I've seen it happen. A wheel not, after a while, it's spinning 20,000 times a minute, the screw gets loose and whoosh, goes across the room, and what happens? So always protect your eye. Tell your girls to fold your gauze, to protect it, and doesn't catch the edges, but you must always protect your eye and watch your teeth. And other than that, you'll be in good shape. When you're doing your lips, I change direction of my wheel. Let me explain. On most of my cases, I am going in a clockwise manner. The wheel is progressing clockwise. When at the mouth, when I go to the lower lip, I change direction to go counterclockwise. Otherwise, I find that sometimes my wheel will go run off the chin. I try not to go too far below the angle of the jaw. I've seen some scarring there, and as you know, dermabrasion is strictly to be avoided on the back and the chest. It doesn't work. It doesn't, I've done it for tattoos, it doesn't work either. I now have an argon laser machine in my office, I use that. If you want to be smart, don't get involved with dermabrasion tattoos. If you want to try salivation, fine. Dermabrasion, you get scarring every time. After my patient is fully dermabrated, I reapply again the ice. It's soothing. Then I'm ready for my chemical part of the procedure. I find the chemical part, I've tried the chemical peeling both before dermabrasion and after. I think it works better, at least in my hands, after dermabrasion. You must be careful what you're using. If the patient is very pigmented, you be very careful. I never use phenol anymore, because don't forget, you have no more barrier. Almost systemically absorbed immediately. You've taken all the skin off the face. You're down several layers using phenol, unless you plan to monitor that patient with an EKG and be prepared to spend another hour and a half and have no control over that, because I think phenol, once it's there, it's there. You're not going to neutralize that too quickly. I'm now using different concentrations of trichloroacetic acid from 20% up to 50%. And I also, when I make my concentrations up and make them new, I may add, depending upon what I'm using, some concentrations of DMSO. I find for me, 2 or 3 drops in the bottle, I get a better spreading effect. We all hear about DMSO, and I've been experimenting with it over the last few years, and for me at least, I find it pretty effective. I like it. So again, if you use 20% or something, you're not going to have much of a problem. If you want to get more of a deeper effect after healing, you may go up to 20 or 30%. If you're not sure, use a lower concentration. You won't get into trouble. But remember, you've denuded the face, and there's more concentration, you can definitely cause cicatrix. You can cause scarring, you can cause ectropions. You must be careful. After I've used my acid, and that's painful, the patient should be aware, or you want to give the patient a little extra Valium before you do it, you can do it. Then I go ahead and I neutralize just with tap water. After that, I dress the face with either Tyson ointment or bacitracin, and I further dress the face either with the Vigilon, which I keep in my refrigerator. It's very soothing. It doesn't have to be sterile. That's one of those semi-synthetic dressings called Vigilon. Very effective. You can use Opsite. I think the Vigilon is better. And I think Dr. Creel will tell you, since I told him that I think he liked the Vigilon, am I right? Or else Vaseline gauze is very effective. This Vaseline gauze cut to different sizes, and we begin covering the whole face. Then I follow with gauze, and I tape the face with cling. Patient recuperates in my office for an hour and a half to 2 hours, and I have one of the men work for me. We keep one of our cars outside and drive the patient home. They are all on steroids on a descending schedule. They get an injection of 25 milligrams, or perhaps 50, depending upon how I feel that day, in the buttock. And they're taking cortisone 8, 7, 6, 5, 4, 3, 2, 1, and 5 milligram prednisone tablets over that week period. Bandages are off the next morning. For 5 days, I'm having them again on the bacitracin or Tyson ointment. I don't let it dry. That's important. After that, I begin with the triamcinolone cream for 5 more days. If I operate on Friday, my patient can proceed back to business by Thursday or Friday of the next week. So you have these people who are out of work for 2 or 3 weeks. I don't know why that is. My patients are back to work within 5 or 6 days. They're red, yes. They're lobster-like, yes, but they can function. It looks like they've been to Florida for a few days. which is one of our vacation areas in the United States. Okay, so I think I mentioned most of the things I wanted you to know. And of course, I wait a while. The patient, I have them come back about a week and a half afterwards to examine them, to talk with them. And then I tell them if there's any little areas of scarring, I may go ahead and use a collagen preparation, or the punch elevation, or I'm very happy with the punch grafts from behind the ear. Depending upon the area, you must correct. That's important. The human eye will not pick up a graft of less than 2 millimeters. If you take I've done 12 punch grafts in a matter of half an hour behind the ear, different areas in the face. It's a very nice technique, it works, it's beautiful. If it's big, don't begin to do it, because it's not going to work. It's going to look funnier, and maybe better off just using collagen or perhaps another area of the dermabrasion. So that's you'll learn, I'm sure you've had it in your own experience, but if you're not sure, talk to someone about it before you do it. You don't want a big little round spot right in the middle of someone's face. They don't take kindly to it. All right, again, I want to repeat, in my experience, I think silicone is very dangerous. It should strictly be avoided. So, we're going to show you some photographs, but is there any, I think any of the panel members like to talk about something they've heard or they've seen or they'd like to talk with the audience about, or even me? Yes, Doctor?
Yes, Mr. Moderator, I have also very perfect correction, but something I want to ask is you have to tell the patient why the acne pitting scar happened.
Well, I thought I mentioned that. We do. And we tell them acne heals with scar. Acne will not just go away.
Yes.
Many doctors say, oh, don't worry about it, it'll go away.
Yes,
it doesn't.
Yes, the point which I want to talk, I mean that usually the patient try to create the scar by himself.
I don't believe that's true.
Among our patients, usually if they have inflammatory region, they try to squeeze it out by himself or herself. So that make the scar, that create the scar. But before I do my technique, any technique, I will tell them, for next time, you have to know that you try to avoid to touch the inflammation lesion on the face. That can prevent the scar. You know.
Let me just comment 1 second. I don't believe the patient, in a small percentage of cases, yes, the patient can cause a scar. I believe the acne lesion itself is what causes the scar, not the patient merely playing with it.
Oh yes, but
a very small percentage happens that way.
Oh yes, I think in your country maybe the education is good, but you know what? Among some patients, they tell me that the physician, you know, squeeze the inflammation lesion out. That way created the acne.
Well, I personally don't believe that, but I'll tell you, if you'd like to invite all of us to visit you in Bangkok, we're going to come there and inform the whole city what they should and shouldn't do. Is that okay?
Because I have, you know, I have my friend, I want to tell my friend or something.
Dr. Khalil, will you tell us what you found since we've been discussing this procedure?
Yes. Well, Dr. Fetter introduced me to his combined technique in New York, and I started to use it a few years ago. And it has been very satisfactory in my hands, and I rarely use phenol now, and frequently use the trichloroacetic acid in combination with the dermabrasion first. I do a couple of things differently because each of us seems to find those little nuances that work better in our hands. The differences are very minimal, and basically I could probably summarize them in that those points that I think matter. I use the Vigilon dressing, which Doctor described, for its soothing effect and for its coverage, and also because I feel that since it's an occlusive type dressing, it will drive the acid deeper and really amount to being a closed peel, the same as taping the face, in phenol, and therefore I'm going to convert whatever strength acid I use to a stronger acid in its effect on the skin, since I've already dermabrated it. And I think we should remember that if we are going to use a dressing, that in effect of the acid that we use will be greater than the actual concentration. A couple of other things that I do, that's really not different than what Dr. Fetter does. It's just a point of expansion on it. No, I don't always neutralize it, but I usually only use 20% so that I don't feel it's necessary. I think if I went higher, then I would neutralize it. I do agree with the point that he made and like to emphasize it, that I do have my solutions made fresh because I'm always afraid of evaporation and unexpected increased strength of my solutions unless I'm using them, very rapidly. I don't use any more dressing than that. I do have the patients go home with it and remove it the next day. And although I do use steroids, I do believe that it does reduce the swelling, as Dr. Fetter does. I'm not quite as intense on the type of ointment that's utilized post-operatively. I have many patients that feel that vitamin E will do almost anything except pay their bills. And I don't object if they wish to use vitamin E. If expense becomes a problem, I've used Crisco or shortening that they cool in the refrigerator. I think the important point that he made is to keep it soft.
Yes, I think it shouldn't be allowed to dry, basically, but that's a trace of without it for $1, so it really, I think Crisco costs more nowadays, huh? Okay. I think we'll go to a few of those pictures now that I brought to show you. And I must say the results, at least in my hands, I'm very pleased. I do chemical peels also, by the way. I've done phenol peels. I do trichloroacetic acid peels. But I think for the vast majority of indications that I see, the chemodermabrasion procedure has been one of my really enjoyable procedures, and I think my results have been very, very good. And I just like it. I want to bring all these nice pictures to you now. If you have any questions, we're going to come back to the audience in a moment. Now, can we have that first case, please? And we'll go back to our nice panel also in a moment. All right. We have on our left, we're going to have our before and our after. Matter of fact, this young patient had been dermabrated in the past. I had done a television show in New York about 2 months ago called The Morning Show on ABC, and she was part of the audience. And after the show, she'd walked over to me and she'd said, "I'm just so unhappy. I don't want to go in the street. I just feel terrible about myself. I went and had some surgery done, and it looks terrible still." And her sister was with her. She has 4 sisters who all have a severe scarring disease. As you well know, this acne problem does run in families. Her mother also had it. And I said, well, look, why don't you come and see me and we'll see what we can do. Now I'm going to show you some Polaroids and some Kodachromes in this particular case. This girl's about, I think she's about 21. And if you look at her right side of her face, you see some very prominent acne-form lesions, crater-form in nature, and she still has some active acne cystica. This is exactly 7 or 8 days after the chemodermabrasion. Now, if you notice, she's Spanish of descent, and she's kind of that olivey complexion. But you can markedly see the change from the right to the left. I went back, in fact, about 2 or 3 times to that area to level that out, and I think I'm very pleased, and so is she. I'm going to probably give a little collagen just to touch up the fine-tune points when I return to the United States. Next case. Next slide. This is more of the same. Now, this is the left side of her face. You can see the crusts are just about falling off. This is about only, 5 to 7 days later. Next, please. And this is the central part again. I'll just give you some more of the same case. And she had, minimal to moderate discomfort. I don't believe in pain. Next. This is some Kodachromes. I think she was in heaven on the right side, and she wasn't sure what was going on. Go on, please. Next. This is a close-up again on the right side of the face. And you can see an area there on the right side that will need some little adjustment. She's so pleased with what happened, she said she wanted to go for a second dermabrasion. We're going to discuss whether a dermabrasion is the answer which the very severe cases may take a second dermabrasion, but many times just some collagen filling substance will be satisfactory. Next, please. And again, you see how nice, and also the skin feels so much softer after this. The patients just report the skin feels so much more luxuriant and soft and more comfortable for them. Next. Here's a man who didn't have very severe scarring, but he had just a very kind of a tired skin. He felt that he had acne as an adolescent, and he was just tired of these scars, and he wanted to know if I could help him. I mean, he's of Italian descent, and he's very dark, and I've had no problem with him. Again, if we have a pigmentary problem, it's easily bleached out. We can use acids, or we can use the Eldequin Forte. Of course, remember, after you do a procedure like this, you must tell the patient they cannot go in the sun at all for 6 months. And I mean at all. They must go in the sun a block. If they're on the beach under an umbrella, they still get a reflection off the sand, and there's still things called windburn and things of that sort. So you must inform them that they must wear sunglasses and a block when they're going out in the sun, along with a hat or under an umbrella, something like that. Very important. Next one. This is central. This is only about 5 or 6 days after I've, and on this particular left side, I injected some of those areas also. He still had some active acne, so when I saw him, I injected some of those lesions with a 2.5 milligram per cc corticosteroid into those areas. Go on, please. Next. Yeah, but you see how he's healing now. Much smoother. He's very happy. This makes a happy patient. Really makes them smile. It's a whole thing, even more so than what you see structurally. Psychologically, this is the most rewarding procedure you can do, along with nose and anything else, but especially with an adolescent. They can have the worst medical disease, but they don't see it. With acne, with a scarring face, that's with them 24 hours a day plus. It affects their whole life. Next, please. Ta-da! Is that it for that one? There it is. Okay. Next, please. Next. This is how it looks right after we finish dermabrasion. This is the acid effect. See that whiteness? It looks pretty bad. When you walk away after you've done your first few cases, I use 35% trichlor in this patient with in DMSO, and I'll tell you, it hurts. But you can imagine in 6 to 7 days how much it's just an incredible turn of events, how quickly the face heals. Remember, the vascular supply of the face is so great. You have such a nice margin of safety. If you have a nice feel with your hand, remember, I think it's a mistake to try this procedure or anything else unless you really have a feel for it, because it's just as easy to scar the patient as improve them. But if you like this procedure and you really feel good about it, it is one of the most satisfying things you can do for your patient. Next, please. This girl is a model. She's a very lovely Swedish girl. As a matter of fact, she was on television doing a fashion show for my girlfriend at 10 o'clock on the morning show on Channel 7, ABC TV, and at 12 o'clock operated on her. And she came out very, very well. She had gone to a doctor who was just giving her collagen injections. She had 8 collagen injections. But the problem in this case was not, she had a lot of ice pick scars, and she had the kind of scars which I didn't feel was particularly amenable to collagen, and collagen was not the answer. So she went for 8 cc's to a doctor who unfortunately was not a surgeon. And he gave her the collagen, and it didn't work. And it was very unfortunate. We dermabrated her with a chemical peel, and she was very pleased, and we only had to touch her up with about 1 cc of the collagen. She's much, much better. She's very pleased. This is the ideal case to operate on. Blonde, blue-eyed, and very lovely. Next, please. This patient had severe actinic sun damage, and she'd gone to somebody who told us she has cancer of the face, and she has these things, and she had a lot of keratosis. Some were actinic, some were what's called senile, but mostly actinic damage. When I operated on her, she was not a very good patient, and I gave her a lot of medication within the framework of good medical judgment, and she said when she gets home, she's going to get a voodoo doll, and she's going to put pins in it for the next year, and if I don't sleep well, I should know that it's coming from my friend here. But nonetheless, she healed particularly well. I want you to see this is exactly about 7 days after surgery. So you can see her skin, unfortunately, that pictures are not as good as I'd like to have them, but that's the best I have, unfortunately. She had, again, a diffuse irregularity, she had raised keratoses, she had hyperpigmentation, she had an occasional acne lesion. All in all, her skin looked very tired, and of course she was a sun girl. She went in the sun. You'll ask a patient, do you go in the sun? No, I never go in the sun. But how about 10 years ago? Oh, 10 years ago I lived in Palm Beach, I was in the sun 10 hours a day. So take your history, you'll find that almost invariably you're going to find these patients have had some severe sun damage. Next, please. Again, this is a patient who has light eyes, and it's a better case to operate on. Next. Notice how smooth, it looks smooth and it is. She was very happy. This girl's she's about almost 60 years of age. I think she's about 59, and her husband gave her this present, and I must tell you, she's very, very pleased. Next, please. These are my, when I take photographs in my office, I use an icon, and I also use my Polaroid, so if I misplace something, I need to have some record of what I'm doing. I think it's very important. Next, please. Next. Okay. Next patient, please. This is a young woman who was about 25 who had had ongoing acne, very pretty girl. But again, she'd had about a grade 2 acne through her life, and she was just tired of it. So we, as you see on your left versus the right, she had the kind of scarring that was rather diffuse, and the kind of skin that was just kind of a tired skin, and she was very, very displeased, but she's a very attractive young woman. Next, please. No, Michelle, I will not give you her telephone number. You know, when you see Michel Hishmati in Cannes, he's a wonderful host. When we walk out after a surgery, he puts his little white leather jacket on. He stays the white for the sake of medicine, as you see. And we walk to the beach together, and every girl has a beautiful body seems to know Dr. Hashmati. So it's a wonderful job he has over there. Next, please. I think she had a little bit of a polyleaf there. I think I should send her to one of my friends here. I think we have to get Dr. Fisher to meet her, or Dr. Brown. Yes, next, please. This woman was a very famous model in the 60s, now is married to a very dear friend of mine. And she also was very much in Saint-Tropez in the south of France and then Marbella. And she was a blonde, blue-eyed, 6'1", and a particularly lovely person. She's from Holland. And she said, you know, Louis, I'm tired of this tired skin. I have all this pigmentation problem, and she did have a yellowish cast to her skin. We decided to operate on her, and I think we've got a wonderful result. She was a little hyperpigmented after surgery, but if you just leave it alone, and perhaps if you're a bit concerned, give them some more triamcinolone cream, have them apply it twice a day, it will lighten. Don't get nervous, especially the patient who has fair eyes. Nature will take a wonderful course. It all can be lightened, especially in the fair patient. The dark patient, they also can work. So don't get nervous, start to pull out your hair if you see some hyperpigmentation. Next patient, please. That terrified look on the left is because she was just about to go into the operating room. Next, please. But as you can see over here, how much whiter and more attractive and softer it is, and it is. Next, please. I think, is that all the slides we have? Are we finished? I think we are done. The ones I wanted to show you. Okay, so now I'm going to ask the members of the panel their experience with dermabrasion. Dr. Giorgio, what do you think about this procedure that I'm doing?
Well, you know that, you know that I've been in New York with you, so I'll do the procedure just the same. The only thing I help myself, even if it doesn't last long, with a lot of Xavier before, and after.
Yes. It's interesting, when I had the great pleasure to have Dr. Fisher in New York. I have my own television show in New York for the last 3 years on cable. And I've been on each Monday night and discuss cosmetic surgery and health and nutrition. And we've had some very famous people on the show. And Dr. Fisher and I we did 2 shows on advances in cosmetic surgery. We discussed the meeting. He just come from the plastic surgery meeting in addition in Las Vegas. And of course the one we went to in the American Board of Cosmetic Surgery meeting in January, which by the way, I'd like to invite you all to. It's a wonderful meeting each January. And we did this show, and Dr. Fisher showed his grasp and other techniques about how we glue the skin together and how we take care of the wrinkles around the eyes. And all these patients, they kept saying, how do I find this doctor? I told them, all the women wanted to know where Dr. Fisher was. So I'm glad you're in Rome and I'm in New York, Georgia, I must tell you. Yes, Dr. Brown?
Yes, I wanted to thank you for a wonderful talk on a most complex problem. I think acne scarring is extremely distressing psychologically to many of the patients, and I find it probably one of the most difficult procedures to get a really nice result. I think the chemodermabrasion is a fine addition to this type of problem. However, in my practice, the question that I have is, in my practice, I have done black patients' dermabrasion, and I have gotten nice results, but most of the time I turn it down, and there's a whole slew of patients out there with acne scarring, patients with pigmented skin, dark complexion skin, Mexicans, blacks, some Orientals. I'm very cautious about taking those on as a patient. How do you feel about that?
I think that's a very good consideration. If you have any question about it, I think it behooves you to explain first to the patient that pigmentation is a consideration, because remember, the difference between black skin and white skin is merely by the number of melanocytes. When you are doing dermabrasion or chemical peel or anything like that, you are stimulating melanogenesis. You are stimulating these cells. So to protect yourself, I think it's an excellent idea to dermabrate the patient behind the ear. See how it looks. The patient is very happy and very pleased. Make that patient your friend, so if God forbid there is a complication, you're not going to go to litigation.
Have you ever done a total face of chemodermabrasion on a patient that's black?
Yes, I have. And remember, the different types of black, too. The black patient is scary. Because they come back and they're white here and they're black there. It's scary, but they pigment back.
How long does it take for the
It takes a good 2 months. So don't be scared. Call your friend, and say, look, what do you think? You can always call me, I'll tell you not to worry. The worst thing I can do is say I lied, but I don't. Dr. Hashmani, what's your experience with this?
Yeah. I simplify, and you saw my compression room. Every compression must be very easy for you and for the patient. As you know, the healing by phenol, I know 20 years is experienced by Fournier, that he was first in France and Little in Washington and Jury in Argentina. I watched 2 of them carefully do very nice healing by phenol. Little in Washington. Jury has been a problem with this in Argentina because the sun. Because many things together that we must think about. First of all, what is the origin of the acne? And we must do some treatment because that's in the cranial cause. And sometimes you do your peeling very nicely as you do, but a few years later the patient comes with the acne. So you must also do hormonal dosage and do the treatment if they have hypercellulite, then hormonal dosage. First, before than anything else, you do the treatment for stop the origin and reason of the acne. But about the different technique of dermabrasion, by the machine I don't like. I never used it, I didn't like, because before I give satisfaction to my patient, I must be satisfied. I never be satisfied by this machine because I like everything feeling by feeling. I call the last and the simple way that I use, and I didn't know that this time we speak about the peeling. The next Congress in Paris, maybe, or in January in Los Angeles, I present the new peeling by feeling. And this diamond peeling by feeling, it is by surgical glue, by different form that you can really easily use on the face without any risk. As I say, after 20 years experience, I prefer lose 4 or 5 patients that lose my reputation. I accept when I am sure on me 100%. By this new procedure of the diamond peeling, by feeling, you can have successful 100%.
I'll show you one of these wonderful ideas. I mean, healing by feeling sounds like what you're doing on the beach.
Oh yeah, really? I'm telling you, the many doctors that come to my clinic in Japan and they assist this new technique, they can tell you really that the patient immediately during the operation, they can watch by the mirror the peeling that I do to them. You know, the peeling by phenol or dermabrasion, you say 9 days, don't look to the mirror. Immediately, I show them how no local anesthesia, no general anesthesia. Very gently, as I say you, by really feeling. You clean all the face. There's 3 kinds. One is very small for superficial, another they are very sharp, and the third one is very deep, that a little bit bleeding. I put just for 3 first days the dressing by the antibiotic, the tulgura by the antibiotic. After 3 days, I take out this antibiotic, tulgura, and I put the cortisone for no scar. And 6 days, they looks good. 9 days later, I mean a week, maximum 9 days, they can go to the work, as you say, with a nice
We'd like to see some photographs.
Yeah, I bring you, I didn't know that today.
You know, it's
they changed the
interesting.
price. I bring it in what?
I was in a symposium a while back, and they had some people from beauty parlors and stuff.
Yeah.
And they all maintain they can do peelings and all these things. I said, well, why don't you show us photographs?
Yeah.
I'm a bit more humble. I'm not thinking just you.
Yes, sure.
So, you know, a lot of these facial places, once doctors don't really do a proper peel or proper medical treatment, and mind you, acne will be ongoing if it's an acne patient, I'll still treat them. I don't just discharge and say goodbye, because the acne will go on to scar. So I had these very fancy ladies from New York who run these beauty parlors, and I said, well, why don't you show me some photographs? They said, Dr. Federer, our people are so rich and so famous, they will not allow us to photograph them. I said, oh, I understand.
Now we can put something on the eyes. But the last thing that I put on a scar, deep scar, it is corticoderm, as you know,
Yes.
they stay longest than collagen.
Yeah, so we're going to be following that with that when you get that much money. You have to bring us some more photographs and more
Yeah.
follow-ups. I think it's a wonderful
I'll explain
innovation
to you
you've
more
done.
than 100.
Dr. Fisher.
I want to ask Dr. Class, what about, why doesn't he like neutralization after? Makes or make, you think it doesn't make the difference?
I don't neutralize it as I thought I made clear because I only use 20% solution. That's why. And I don't want to lessen that. I want to increase it, and which is why I address it immediately to include it. And I feel I'm getting the effect then of 25 or 30%.
Yes, I think it's a good idea. But if you go on a higher person, I want to emphasize that
Then I would neutralize it.
you have to neutralize it afterward with cold clothes and leave it on, because otherwise you really have a deep peeler.
No, I agree entirely. I thought that I had made that clear. Perhaps I didn't. With a stronger acid, I would neutralize,
Yeah.
but with the 20%, I don't. I wanted to ask Dr. Hashmani a question. With your diamond peeling, do you get a crust or not?
What's the crust?
I mean, the healing crust, does it?
No, absolutely not.
You don't go deep enough to get a crust?
No. Because even this cortical, I think, helps a lot, you know.
But the reason I ask is that at the present time, we're setting up a project at my institution to do dermabrasion by microcomputer using a laser and setting it to specific depths at different places on the face so that we map the face by computer and map the depth at the different areas of the disease, and then we're going to dermabrate it at that set level and try to measure the difference. But I haven't figured out yet how to measure the depth of the
We
burn.
are going the next time this new.
Let me just make 2 points, and I like that, what you asked, Dr. Fisher. Now, remember what you're saying, whether it's 20% of acid or 25%, you might as well double that, because you've taken away all that superficial protection of the face. And this is why I've done both, Richard, and I must say, it's a scary thing when you must know where you are. With phenol, you've lost control, because once it touches tissue, it just does its own thing. With trichloroacetic acid,
Skin like a snake.
right through, bam, finished, next, medium rare. With trichloroacetic acid, you must neutralize it because then you'll know your depth. You're getting your occlusive effect anyway, but you must neutralize first because if you put in even 20 or 25%, any factor, it may be 50%, it may be 75%, because don't forget, the face is denuded. And you're getting systemic absorption of trichloroacetic acid. That's why I don't allow myself to cover the face until I finish neutralizing. And the way I neutralize it, I just put it around. I take several gauze and I just squeeze it all over the patient's face and just drench them with cool water. It's very soothing also. And then if you also, during that period of the recuperation, remember, the patient should be on 3 pillows, and I also do intermittent ice packs. Gently, some ice in some plastic bag, 5 or 6 times a day for 5 or 10 minutes. And it works. It's very, very helpful. And for pain medication, I will use Tylenol with codeine. 30 milligram tablets 2 or 3 times a day. And remember to give them some pills for sleep, because it's very discomforting, that thing at night. There's a second thing that you mentioned, I wanted to mention about the, oh yes, Dr. Kuhl, about the laser. This has been reported in New York, so I think Albert Einstein at the beginning, that I have lasers in my office also. And even though it sounds very nice, this computer type thing, I don't think that any computer is going to take away from the doctor who understands and sees a scar and moves his hand accordingly. Because there's not every scar is the same. In fact, scarring is the most regular thing you're ever going to find. You may, if you do a traditional, standard, light dermabrasion, fine. But you'll find invariably you'll have to go back for those areas to repair it. I've seen how they're using it at Albert Einstein, and it's nice, it's a nice gimmick, and it may indeed be effective, because you mentioned to a patient laser, they all go crazy. They get very excited about the idea of the laser beam. It may have some indication, but I'm sure we're going to hear a lot more about that. I hope you're one of the first institutions to really get some nice publishing on that. Okay. Dr. Brown, you want to ask something?
I wanted to ask a question of the laser dermabrasion. I've heard a lot of talk, hearsay, that does work for acne scarring, and I can't quite figure out why that would be true, but could you make some more remarks about
I
that?
think nothing much has been done to date. I mean, some of the institutions around the United States are going into that with basically a CO2 laser. I think it remains to be seen. The only news shows in New York and the large cities are discussing laser surgery. So maybe Dr. Clee will be able to report to us at our next meeting what's been done in 2 years in the Bahamas. We'll find out all about laser surgery for this, and maybe I'll fly out there and do some work with you. I'm looking forward to that.
Actually, what Dr. Feder says is true. I really can't give you any real results, which is one reason why we're going to try it ourselves. But I've changed my approach to some other problems because of my experience with this particular technique of dermabrasion with chemical peeling, because I consider it a burn, and the thing that concerns me is the lack of control that we have. Really, a great deal of it does depend on experience. How does it feel? How deep does it look like you've gone? How much acid do you put on? How deep a burn have you created? A great deal of that is really related to the experience of the operator. And what we're trying to do is to quantitate that to be a little more predictable as to what we can expect at different levels and what we can predict. As far as the laser goes, using the CO2, we're just trying to control our burn and be able to actually give a measurement and then measure the results that we get. And I hope I'll be able to report. It may be a negative report. It may be that it's not a worthwhile situation. But I've even changed my approach to treatment of facial burns. The idea of slathering them with the various silver compounds and the other medications that we use to prevent secondary infection and things of that type, if I produce intentionally a second-degree burn of the face, and I don't do those things, why must I do it to an accidental burn of the face unless it's more severe than that? And I've gotten very nice results faster treating burns of the face that are first and second degree as I would treat one of these patients with nice results faster than I have treating them with traditional burn therapy. But you have to pick that case, of course, that there's no third degree loss.
I'd like to comment on why I think this is true. The vascular rapidity in the face, I believe, is in great part. You really have to have a real bad technique to get infection in the face. The vascular supply is so rapid, and so quick, the healing is so intense. I believe in great part burns to the face, which is what we're talking about. Dermabrasion in and of itself is a burn. And then you're compounding it with the chemical peeling. It's not like 1 and 1 make 2. These two procedures, 1 and 1 can make 4. And that's why I said to you, it's most essential that you neutralize, and you'll know, you neutralize your acid, you will know exactly where you're going.
One point about a burn, I might make a comment for those individuals who might be starting dermabrasion. There seems to be a tendency to think, well, I don't want to use a coarse wheel because I want to have better control and use a fine wheel and so that I won't go too deep. I find that frequently an inexperienced operator will then take a fine diamond wheel and burn the patient because it takes them so long to dermabrate the area down to a significant level that it's created a friction burn and actually produced the problem. Where, in my opinion, a coarse braze is better because it's faster with less chance of burn, and really the control factor comes rather quickly, I think.
Yes, I have a question from the audience.
Well, okay, thank you very much. The difference, thank you very much for a nice presentation. I've got quite a few questions to put to you. Firstly, Dr. Leder, how long does your procedure take in total?
My operation takes about an hour and 15 minutes.
Well, fine, that's good to know. In your post-auricular test patch,
I rarely do them.
right, okay, I don't think they're any use because I don't think they're indicative, and I do a test patch. I do it on the face, a very light test patch if it's, if I really think it's necessary, and I certainly will do it in all coloured skins. I'll do it, and I do it here, and I explain to the patient they take a risk of having a penny-sized thing, and they take it on. It rarely happens, but there it is. And could you comment on the following? Your S-star, or whatever it is, separates about 5 days.
Yes.
I think the time of scab separation is a function of the depth of dermabrasion. If you do a very deep dermabrasion, it takes a long time. Now, the reason for saying that is, in the technique that I use, I get the same situation, 5 to 6 days, almost to the dot. You get separation of scab. And that would tell some of your pictures, which I think are good, and I actually warn my patients. I don't see my patients at 7 days because I say to them, you're going to look really good at 7 days because the edema, it flattens the pits, and if you're going to have recurrence of those pits, obviously you're going to improve it because we've been taking off a layer of skin. But don't be deluded. Come back and see me in 3 weeks, by which time the bulk of the edema is gone, and I can just reassure the patient, make some plan to see them again. But I would never see them at a week, and I actually warn them never to take, at first appearances, what happens at a week. And
Well, I bring them back for a week, mainly to reassure them.
Yeah,
That's what I,
well, that's fair enough.
we obviously have edema. I'd like to bring it to the attention also of the audience about the actual instrumentation. The machine that I usually use is the Bell hand engine, which goes approximately 20,000 rotations per minute. Now, there is a new machine out which goes up to 60 and 70,000 times a minute. I don't like it. I think it's not going to get any much more better treatment of the patient, and I think you can go and cause some real trouble there unless you're a really, really experienced dermabrader. I've done now almost 2,000 of these things, and I'm still scared, and I do it because it is a very, very fast-moving procedure. You don't have the option to just go back like you're doing in a facelift or an excision of a cancer. It's a very scary thing unless you really know what you're doing. And to use a wheel that's going 70,000 times a minute, you're not gaining anything. So when you're going to buy this equipment, if you're considering new equipment, try it out and talk with some of your colleagues before you go ahead, and they'll try to tell you, oh, this is a new engine, it's fantastic. It goes 70,000 times a minute. No gain.
Well, can I just make a comment?
Yes, please.
The device that I showed this morning, you talk about you've got the bigger circumference and you increase your peripheral speed, but it doesn't compare anything to sort of speeds 20,000 rows per minute. This doesn't exist. I take your point about covering the eyes, but of course it's more important it's something that's doing 4 or 5, up to 3 times the speed of the device that I'm using. Let's just make a point.
But yes, it's still sharp, and those upper eyelids are easily lacerated. You don't want that. Anything else anyone would like to ask us? Because this is one of my favorite procedures. Yes, doctor?
Dr. Feather, I have several questions to ask you.
I was hoping so.
The first one, do you go under the, including the lips,
No, I don't usually do the lips. I go right up to the vermilion border.
the medium border?
Yes.
You don't go to the lips. The number two question
Yes.
is dermabrasion and trichloroacetic acid or phenol, which reacts to the skin, makes the patient younger.
It doesn't make them younger, but they feel younger and they feel better about themselves.
How about dermabrasion?
Well, I said I've done both. I just find that my results, at least in my hands, and the people who I've shown this technique to, with different acid concentrations and the actual application of it, I believe my results are far superior with this new procedure. I'm not the first one to do this. I'm not the last one to do this, but I've made it my thing, and I'm really with one of my studies, and it's one of the most exciting procedures because seeing the results that come back to me after 1 or 2 weeks after I operated is literally thrilling to me. Dr. Colino.
The other question I would like to ask is, do you take after chemo surgery,
I don't understand your question. You have to...
do you take trichloroacetic acid or
Usually
phenol?
no, usually open. I don't usually take.
You don't take?
No. I think you lose some control, at least in my feeling, on some of those cases. Now, if you really want to do a deep phenol peel, I have taped and I have not taped. If you do the phenol peel, be prepared to spend the time. Be prepared to have your patient monitored. Phenol is definitely renotoxic and liver toxic. You want to do it over a good hour and a half. So remember, get them scheduled to a EKG and be prepared to do it in sections and to spread your time. Our time is almost up, Dr. Glue, so this is your last thing before we're going to sign off.
One word just to say, I think the doctor is trying to establish why this might be recommended over more classic technique. I will give you the reason that I have started to do this. I find that my results are just as good with this technique as they were with deeper dermabrasions and longer convalescent periods. I think the patients are getting as good a result and recovering faster in my particular hand. And that's really the main reason I've changed. I believe you can get as nice a result doing just dermabrasion or just doing the phenol peel, depending on your experience. But in my experience, this has been faster results, less morbidity, and less time involved in doing the procedure, for me.
Because the picture that you have shown, Dr. Feather, there was no black. All Americans, all Caucasians.
That's another way. I'm scared.
You said you were not scared.
I sometimes don't bend the truth. No, I have done this on blacks, but to be truthful, the ones not in very, really the dark black patients, the patients who have pigmentation. You've seen, I showed you Italian people, I showed you people of Spanish descent who do have definite, not Caucasian, like you would find, for example, in the Philippines, and I've had no problems with it. So again, I'm glad I have such a very illustrious panel, and I'm glad I've converted a few of you to my way of doing this procedure, and we hope to present more cases in the future. Dr. Blue, your last word.
My last word. I just wanted to say there is a meeting by the American Academy of Cosmetic Surgery in September in San Francisco, and the theme of the meeting is cosmetic surgery in the non-Caucasian patient. And that hopefully will be a very informative session for those type of problems.
And now we have our dear friend, Dr. Claude Caber, who's going to come up and discuss liposuction with his panel. Thank you very much for your attention.
somewhat surprised that we were able to get a panel together at all. You know, when they asked me to do this, I realized I was going to have to find 4 experts and persuade them to travel all the way to Tokyo and register for this